Right, so the topics are in front of you, what we want to discuss today. So we are discussing three important topics in rheumatology that we have left here. So one is the myositis syndrome, we have got the overlap syndrome, and we have got the acute rheumatic fever. So three topics, or rather three groups here: one, myositis syndrome, overlap syndromes, and the acute rheumatic fever are the three topics for today. Okay. Yes. Okay, so now I can see your chat. We are all live. Yeah, fine. So now we are ready to continue with our topics. So let us go through a quick recap. So today what we are going to do is first complete our topics, and if time permits, let us go through the images of rheumatology and try to revise what we have done so far, so that, as I promised on the first day, that we can become a fellowship in rheumatology at least, right? Okay, so let us start with this first level. App is crashing a lot today. No problem. Let us try to go. We'll try to go step by step. Okay. So we are starting here. Myositis syndromes. So we'll be doing myositis syndromes, which has three topics. We have got polymyositis, dermatomyositis, inclusion body myositis. Then we are going to discuss overlap syndromes, which include mixed connective tissue disorder and lupus, which we have already written. Okay, on the first day of rheumatology classification, we have written, and we are going to complete our rheumatology class with acute rheumatic fever. So that can be a continuation. That can be a continuation into the cardiology class that we will do later on. Right. So let us start with the first one. So we are going to discuss all these topics in simple tables. We'll make simple tables and charts so that we can understand the essence of the topic. We have already decided that what are the points to discuss about each disease. So let's get started. Yes. So parameters. We'll divide the myositis into the three. All of you. We are going into the first one. Okay, so we are starting with the first one. So we have got the first one. After HSP, we completed Behçet's disease yesterday, one page, and today we are starting with first slide. We are start with the first slide, that is a myositis syndrome. Starting with the first page, that is myositis syndrome. I want you to make a table. I want you to make columns, one for the parameter, one for the polymyositis, one for the dermatomyositis, and one for inclusion body myositis. So these are the 3 points which we want to plan. So please let us start with this. Make the simple table. In this table, we are going to write our proforma from definition to prognosis. From definition to prognosis, we are going to discuss about the myositis syndromes. So myositis syndromes basically are a group of disease, and as the name says, which has got inflammation in the muscle. Group of disease which says there is inflammation in the muscle. So let us start with the first one, the description of each topic. Let us start with the description of each topic. Ready everyone? We have made the table: polymyositis, dermatomyositis, inclusion body myositis. We want to start with. So first one, polymyositis. The polymyositis, it is described as the inflammatory polymyopathy. It is described as the inflammatory polymyopathy. We are going to describe it as, because multiple muscles are inflamed in the body. So we'll discuss it as inflammatory polymyopathy. Very simple to understand. What is dermatomyositis? Dermatomyositis is nothing but the inflammatory polymyopathy plus the skin manifestation. So there is a very small difference between the polymyositis and the dermatomyositis. So polymyositis is the inflammatory polymyopathy, while dermatomyositis is the same plus the skin manifestations are present. Skin manifestations are present. That is the difference between the two in their description. Inclusion body myositis is totally different. Inclusion body myositis is a focal myositis syndrome. It is a focal myositis syndrome. So what is this focal myositis? So when we look at this, if there is a muscle affected by the disease, if there is a muscle affected by the disease, the entire length of the muscle is not affected. Only part of the muscles are affected. That is why foci are there within the affected muscle. So for example, if the brachioradialis muscle is affected in the disease, when you palpate, you will see that there are areas of inflammation within the muscle. Entire muscle is not inflamed. There are areas of the muscle which are inflamed. That is why they appear as if there are inclusion bodies in the muscle. The term inclusion body you have actually studied in your parasitology. Then there are inclusion bodies in the muscle. So there are dipictal nodules in the muscle. But please remember the comparison. In parasitology, the inclusion bodies in the muscle are painless. Inclusion body in the muscle are painless. It is the in inflammation, what we are discussing today, inclusion body myositis, inflammation. So these nodules appear painful on palpation. That is why the name is given inclusion body myositis. The name is given inclusion body myositis. Okay, so let us start here. Everybody has written this first line. Prepare the chart so you can come with me easily because our proforma is set. So as we saw, first one, polymyositis is the inflammatory polymyopathy where multiple muscle groups can be inflamed, affected in the disease. Along with this inflammation, if there is skin manifestation present, then we call the patient as suffering from dermatomyositis. Then we say that it is called as dermatomyositis. And in inclusion body myositis, multiple muscles can be affected. Listen to this carefully. Multiple muscles can be affected, but they are not complete length of the muscle, but foci are present within the muscle. And as the name says, itis, inflammation, means it is painful. Inflammation means it is painful. Unlike in parasitology, I told you, where inclusion body in parasitology are painless. In rheumatology, inflammatory conditions, it is a painful condition. It is a painful condition. Continue further to the epidemiology of the disease. Let us continue with the epidemiology of the disease. So first step we have taken, this is the description or definition to the disease, the myositis syndrome. 3 points we want to discuss. So epidemiology we want to see. Epidemiology, polymyositis presents in young females. Polymyositis is a disease affecting young females. The dermatomyositis is also affecting the same age group. Dermatomyositis is also affecting the same age group, that is 10 to 20 years, female more than male. But it is the inclusion body myositis which is different from the others. Inclusion body myositis affects elderly population with a male dominance. Elderly population with a male dominance we are going to have. right? So what we are looking at in the epidemiology of the disease, please you look at the both of them. In polymyositis, dermatomyositis are very similar conditions. Only difference between the polymyositis and dermatomyositis so far are the skin manifestations which are characteristic of dermatomyositis. As you can see, inclusion body myositis is a totally different phenomenon which is affecting elderly males. Continue further to the same we'll continue with the same table. What are the associations with the disease? So the cause of the disease is idiopathic. We don't know what is the cause. So we want to know what are the associated diseases which can present along with this myositis syndrome. Which are the associations along with the myositis syndrome we want to know. So polymyositis, first one, polymyositis, 10 to 30%. Polymyositis, 10 to 30% have autoimmune disease associated. And the topic we are going to discuss next, that polymyositis, dermatomyositis can be a part of overlap syndrome, which we are going to discuss, right? So they can be polymyositis we can get. So in the overlap syndrome, okay? So when we come to this epidemiology, again I am requesting that few students have doubt 10 to 20, 20 to 30, 30 to 40. Anna, what is young, what is old? Please let us again, as I told you one other day, grow up. Anna? So this is not 10 to 20, 20 to 30, 20 to 25. So chikku pikku medicine nahi karne ka re. Anna, let's grow. It is to get an average age of the patient. Age is not an absolute thing. It is an approximate age which is most commonly involved. So what I want you to do is, when you read a particular topic, you need to have a clinical orientation and understand what is important and what is not. Otherwise, you're wasting your time on irrelevant issues and skipping up on the other points. So let us again focus and what is important. Medicine pe dhyan do re. Anna, there are the points that we have to learn here. We have to grow up as an individual, as a person, as a student, as a doctor, as a professional. Anna, so I know it's not that I'm upset with you all asking, but I want you to break that mindset of 12th standard, 10th standard. Break it. Anna, be aware that there will be gray areas. There will be gray areas. There will be controversies. There are 10 reference books. There will be some variation. But what we have to get is the gist of the topic. Okay. So come on. So let's start it. Polymyositis, 10 to 30%. So important to note is that it can be associated with the autoimmune disease. Can be associated with autoimmune disease. It can be a part of overlap syndromes, which we will discuss further. It can be a part of overlap syndrome, which we will discuss further. The dermatomyositis is important. The dermatomyositis is important, right? It is important because 10% can be associated with malignancy. 10% can be associated with malignancy. Which malignancy? Hematological malignancy, gastrointestinal malignancy can be associated with dermatomyositis. So that is a very important MCQ point, that the only myositis associated with internal malignancy, the only myositis syndrome associated with internal malignancy is the dermatomyositis. Dermatomyositis, right? And 10% may also be part of autoimmune disease. 10% may also be part of autoimmune disease. The inclusion body myositis, easiest column to fill, has no association. Easiest column to fill has no association. Okay. So what we are doing, continue it as a story. polymyositis, typically young female who may also have another autoimmune disease, and polymyositis can be part of overlap syndrome also. Dermatomyositis, on the other hand, also affects young females, but it is associated with skin manifestation. And 10% we must be worried and screen for underlying malignancy. Inclusion body myositis is affecting elderly male and has got no specific association. Right? So continue further. Continue the table. After the risk factor, etiology or association comes clinical feature. Comes the clinical feature we have got here. It comes the clinical features we want to record. So clinical feature, polymyositis. I told you yesterday the dictum in medicine. The symptoms of the disease depend upon the site of the disease and the pathology. Again remember, site of the disease and the pathology. Muscle disease. Whenever there is disease in the muscle, typically they present with proximal muscle weakness. So this is again a general rule. Myopathies, muscle disease, present with a proximal muscle weakness. And pathology in this case is inflammatory. That is why they present as a painful proximal more than distal muscle weakness. That is why they present with painful proximal more than distal weakness is the presentation. So we want to understand that the polymyositis. Okay, let us look at the clinical differential. Young female, autoimmune disease and muscle weakness. So what is the differential? It can be myasthenia gravis. Please remember, the differential diagnosis for polymyositis can be myasthenia gravis, because young female is there, disease is autoimmune, and there is muscle weakness. It can mimic, that can be the myasthenia gravis. It can be the myasthenia can be there. Okay, so what is different? Extraocular muscles are never involved. Extraocular muscles are never involved. That is the key point. We all know myasthenia, majority are ocular myasthenia. The symptoms of myasthenia start with ocular complaints, ptosis and diplopia. In myasthenia, the disease starts with ocular complaints. But in polymyositis, which is also an autoimmune disease affecting the muscle in a young female, extraocular muscle is never affected. Extraocular muscle is never affected. That's what we want to know. Right? So dermatomyositis. Dermatomyositis presents with the clinical feature same as poly. Clinical feature same as polymyositis plus skin manifestation. Presentation same plus we have to add the feature. Same plus we have got the skin manifestations of the disease. In the skin manifestations of the disease, we are looking at the heliotrope rash over the face. There is a heliotrope rash over the face. There is Gottran's rash over the metacarpophalangeal joint. Heliotrope rash over the face. There can be Gottran's rash over the metacarpophalangeal joint. Okay, that is over the knuckles. And there can be hyperpigmentation, V sign and the shawl sign. So V sign is basically over the neck area and shawl sign is over the back. Shawl sign is over the back area. There can be hyperpigmentation can be present. So these additional skin manifestation along with the features of polymyositis, you will clinically suspect dermatomyositis. Okay, so this is about clinical suspicion. We will suspect dermatomyositis. We are going to look at this. Inclusion body myositis, as I already described as the introduction, focal areas of the muscle are affected. Focal areas of the muscle are affected. So when you palpate the muscle, there is tenderness over the areas affected. There is tenderness over the areas affected. And it is unique because there is distal more than proximal weakness. So this is a common Viva question, that in myopathy it is usually proximal more than distal weakness. But in inclusion body myositis, you get a reverse phenomena. It is an exception to the rule. You get distal more than proximal muscle weakness. That is how it is different. That is how it is different. Okay, shawl area, you wear a shawl over the back, it covers, no, the shawl covers over the back, over your shoulders, and that area is hyperpigmented. Okay, so these are our clinical presentation. So don't worry, we will see the images. So dermatomyositis, the characteristic skin manifestation is the Gottron's rash. The characteristic skin manifestation is the Gottron's rash. Ana, image you asked for, dikhayenge. Ana? So we have got Gottron's rash that are present over the MCP joints. That are present over the MCP joint here. Okay. So Gottron's rash is the most characteristic symptom, characteristic finding that you will see in dermatomyositis. It is the characteristic finding in dermatomyositis. And heliotrope rash over the eyes, periorbital edema. So there is a little reddish rash with periorbital edema. These are the heliotrope rash which are seen in dermatomyositis. Yes, so images I will post it in the club. So listen to the topic. Anna, you are asking questions which are discussed just now. So that means you are trying to just copy the slide rather than listening. See, over a time, we all have to adapt. Again, we are not the KG and school children. We have that much capability. Trust me. Rather, I will tell it for you. Every one of you has got a above average IQ. Let me tell it for you. And you have the capacity in your cortex and in your neocortex to understand and store the information. Okay, so what we must remember is the clinical presentation. So polymyositis with skin manifestation becomes dermatomyositis. The differential for polymyositis in a young female is myasthenia gravis. Okay, in the myasthenia gravis. Yes, if I say poly and derma, skin muscle is same, that means extraocular is not involved in dermatomyositis also. Okay, that is what we want to know. So continue further. After the clinical feature, what do we have is the suspicion. After the clinical feature, we have a clinical suspicion that patient might be suffering from a myositis syndrome. Patient must be suffering from myositis syndrome. So there is a painful, means inflammation is there, muscle is affected, we think of myositis syndrome. So how do we diagnose the disease? Start with the screening test. How do we diagnose the disease? How do we diagnose the disease? You start with the screening test. You start with the screening test, and it is common to all. The screening test is common to all, and that is creatine kinase levels. Creatine kinase, which is released by the muscle. When the muscle is inflamed, the creatine kinase level can be very high, even as high as 50 times normal range. It can be as high as 50 times the normal range. So there is a common screening test for all the myositis syndrome. A common screening test for all the myositis syndrome. But the diagnostic test is also same in all, that is muscle biopsy. The diagnostic test is also same, and that is muscle biopsy. The diagnostic test is also same. So screening when the patient comes with common are poly and dermato. Inclusion body myositis is rare. So let us think of the clinical scenario when a young female comes with painful proximal muscle weakness. With or without skin manifestation, you think of myositis syndrome. In such patient, you will start with the serum CK levels. If the serum CK levels are very high, it becomes probable that it is myositis. But to confirm the diagnosis, we want to go for a muscle biopsy. To confirm the diagnosis, we want to go for a muscle biopsy. Muscle biopsy will show inflammation. Infiltration of the inflammatory cells can be seen on the muscle biopsy. And that is how the diagnosis can be made. Please remember that in inclusion body, which is a focal myositis, it is rare and usually clinically identifiable. So many times we do not do the biopsy, but theoretically speaking, to confirm the disease, gold standard, we have to perform muscle biopsy. So the question comes to you, from where should we take the muscle biopsy? So the question which is asked in your practical viva, and just to get a clinical orientation to the topic, I want you to think and answer, which muscle will you biopsy? Answer, which muscle will you biopsy? So from where should you take the biopsy? That is the question here. Muscle biopsy is the gold standard test to confirm the diagnosis. But I want you all to tell me, from where will we take the muscle biopsy? Where will we take the muscle biopsy? We want to understand. Where will we take the muscle biopsy? We want to understand. So the answer, okay, where to take muscle biopsy? There is no specific muscle. That's what, it's a concept where you will take from the actively involved muscle. You will take the muscle biopsy from actively involved muscle. Okay, from the actively involved muscle. There is no specific name. Which muscle is affected actively, from there you have to take the biopsy. So it is a clinical point. So how will you know which muscle is actively involved? How will you know which muscle is actively involved? You will know by examination. The muscle has to be inflamed, and if it is inflamed, it will be tender. When it is inflamed, it will be tender. The table is not over. This is just a clinical point for you to understand that the muscle biopsy, that from actively involved muscle, how will we know? On palpation, it must be tender. That means it is inflamed. That means it is inflamed. But at the same time, the power should not be zero. At the same time, the power should not be zero. Because what happens is, whenever the patient has got inflammation, eventually the muscle may get destroyed and atrophy. And that time the patient develops muscle weakness. So if the muscle power has become 0 to 1, that means most of the muscles in that affected area have become atrophic. And if you biopsy that area, you will find only muscle atrophy. You will find only muscle atrophy. So the point is to identify the actively involved muscle. One, it must be tender. If it is not tender, biopsy from the area will be normal. At the same time, muscle power should not be zero. Otherwise, the biopsy from that area will be atrophic. So, otherwise, the biopsy report may be normal or atrophic. The biopsy report may be normal or atrophic. That's what we want to learn here. So, site of the muscle biopsy, you have to choose wisely. So screening test is creatine kinase, and then you will choose the actively affected muscle and take a biopsy. If the biopsy shows inflammation, infiltration by the inflammatory cells, that means the diagnosis is confirmed. Diagnosis can be confirmed. That's what we want to know, right? So what is the next point here? Myositis syndromes. Myositis syndrome. Continue the table. Continue the table. So we have reached till the diagnosis. So we started with clinical suspicion. We did the screening test. We did the diagnostic test, and we reached the final diagnosis. So next step comes the treatment. But before treatment, we want to take a look at the additional test that you want to prescribe. So diagnosis has now come that it is polymyositis, it is dermatomyositis, or it is inclusion body myositis. So along with the treatment, you also want to prescribe certain additional test. Why should we do this test? Please recall from the same table why we should do additional test. Because of the associated disorder. To look for associated disorders. So we want to go for associated disorders. So we saw polymyositis can be associated with other autoimmune disease. Polymyositis can be associated with other autoimmune disease. That is why you go for ANA screening. You go for the ANA screening. But at the other time for dermatomyositis, along with ANA to screen for autoimmune disease, you want to go for bone marrow studies. You want to go for the bone marrow studies. You want to go for the bone marrow studies and pan endoscopy. Bone marrow studies and the pan endoscopy of the gastrointestinal tract to look for malignancy. To look for the malignancy we want to see. Okay, to look for the malignancy. Yeah. So that is how we want to see. Because what we said in dermatomyositis, 10% of the cases can be associated with malignancy. 10% of the cases can be associated with malignancy. So we will have to go for a endoscopy and bone marrow study to exclude or to confirm hematology versus GI malignancy. Okay. Pan endoscopy means upper endoscopy and colonoscopy, both. So upper and lower endoscopy we want to do. Okay. So that is what we want to see. Okay, right. Okay, so this is what we have, dermatomyositis. Additional test I have written because these tests are not for diagnosis of myositis itself. These tests are not for diagnosis of myositis itself. Myositis is already confirmed. These tests are for associated disorder. These tests are for associated disorders. Inclusion body myositis, no further test is important, right? So inclusion body myositis, no further test is indicated because there is no association. No further test is indicated because there is no association. No further test because there is no association. Okay, so that is what we want to know here. So additional test we will perform. What is the treatment? What is the treatment? Okay, I have got, I think, hundreds of the queries. How to differentiate on biopsy, Are you dealing in a pathology class? No, we are not doing pathology class. So when you do pathology class, you can learn to differentiate if there is a difference. Why are you so much distracted? Anna? How can you be so much distracted? You have to know the biopsy finding, but not for medicine. Maybe for pathology, but we want to know medicine here. So every person is trying to teach the subject so you can eventually integrate. I am telling 3 times I have told you biopsy findings may appear same because only thing is inflammation. Poly and dermato are only divided based on the skin manifestation. That's all. Okay. So simple points we want to know. So the parameter continue is the drug of choice. Is the drug of choice. So drug of choice here is to go for the steroids. Anti-inflammatory action. You want to start on the steroids. Anti-inflammatory action. We want to start the patient on steroids. So once we start the patient, you want to know the prognosis. We want to know what is the prognosis of the disease. We want to know what is the prognosis of the disease. Right? So prognosis. Polymyositis has got very good prognosis. Polymyositis has got good prognosis. Please remember, they have got good prognosis. They are favorable because response to treatment is excellent. As we discussed in the context of this topic, 10 to 30% may have autoimmune disease, but that also will respond to the same treatment, that is steroid. So overall, the patient of polymyositis is likely to respond to treatment very well, and hence the prognosis is favorable. When you compare it to dermatomyositis, right, favorable that unless malignancy is present. So dermatomyositis also outcome is favorable unless malignancy is present. If malignancy is associated, the prognosis becomes poor. If malignancy is associated, prognosis becomes poor. Okay, so we want to know dermatomyositis also is very similar to polymyositis. Both can be associated with the autoimmune disease, which we are going to discuss next, and both respond to steroid. So if it is only inflammatory, the outcome is favorable. But 10% of dermato can have malignancy, which can make the prognosis poor. What about other one? Inclusion body myositis. Prognosis remains poor. The prognosis remains poor because there is no or minimal response to treatment. Because if I just say no, all of you will start asking to diya kyun? Why to give steroid? So Harrison says you have to treat the disease, but the response in majority of the cases may be poor. And worse, they also have other comorbidity due to the elderly age. They can also have other comorbidities due to the elderly age. And that is why the prognosis of inclusion body myositis is poor. The prognosis of inclusion body myositis is poor. Okay, so this is our whole table. So once you have written it, start from the top one by one. Let me revise it for you. Okay, column by column, let us revise it for you. So once you have taken this table down, let us revise it from one by one. First, we will start with the green, polymyositis. Read that in a clinical perspective. So 20 to 24-year-old female comes to you with complaints of proximal muscle weakness. That is, she complains of difficulty from getting up from squatting position. But along with the difficulty in the weakness, there is also painful muscle involvement. So you think of a inflammatory disorder, and there is extraocular muscles are spared in the disease. So you will go for the CK testing. CK levels are high. Proceed for biopsy of the affected muscle. After you confirm the diagnosis of polymyositis, you will also do ANA screening to see whether polymyositis is alone or is it a part of other autoimmune disease, that is overlap syndrome. That is why you will do ANA testing also and start the patient on steroid. Once you start the patient on steroid, relief of the symptom is very good, making the prognosis good. Making the prognosis good. Right? Now, let us put on the second side. Second line, that is the blue, dermatomyositis. Let us see. Dermatomyositis, again, young age female, comes with proximal weakness along with heliotrope rash over the face with periorbital edema. They can have Gottron's rash over the metacarpophalangeal joint. They can have hyperpigmentation over the neck, V sign. Hyperpigmentation over the back, shawl sign, can be present. Creatinine kinase levels will be high. Biopsy will confirm the disease. But in this patient, you have to perform bone marrow and endoscopy to exclude underlying malignancy. If the malignancy is excluded, the treatment is steroid and prognosis is favorable. But if malignancy is present, prognosis becomes poor. Last one point here, inclusion body myositis. Inclusion body myositis we want to see. Inclusion body myositis is a disease of elderly males more than female, where the patient comes with distal more than proximal weakness with focal tenderness over the affected muscle. So there can be tender nodules on palpation over the affected muscle. Again, creatinine kinase levels are high. Biopsy can confirm disease. There is no associated disease. So you will start the patient on steroid. But unfortunately, the response to treatment is poor. And also, because of the advanced age, they have other comorbidity which can make the prognosis poor. Right? So this is where we have. So coming to the next topic. So again, let me tell you, there is no specific reason why the inclusion body has distal more than proximal. It is just an exception to the rule. Why it is different is poorly understood. It may be because it affects the distal muscles more, but it is only an hypothesis. Exact reason is not known. Okay, so let me answer your doubts here. Okay, inflammatory disease. We don't know how the disease occurs. We don't know why IBM is distal more than proximal, but it is a typical feature for Viva MCQ practice. That's what you want to remember, right? So come to the next topic. Next topic we have got here is the overlap syndrome. Next topic we have got here for today is the overlap syndrome. Okay, so we have got the overlap syndrome. Overlap syndrome affects the patient, young female. Overlap syndrome affects the young female. Overlap syndrome affects the young female. I will come to anti-Jo antibody in the later after the thing. I will try to explain. Okay, don't get, you are all sitting with then old notes or some notes. Anna, if you have the notes, you know the reason. If you don't have, you don't have that doubt. So something is missing here. You try to focus on what is being done today. Okay, let us focus on what is done today. Otherwise, this is not correct. Overlap syndrome, 10 to 20 years, female more than male. 10 to 20 years, female more than males are affected by the disease. Right? So next step, what we have here, next step is that in the overlap syndrome, clinical features. When do we say the patient is having overlap syndrome? When do we say there is overlap syndrome? We say there is overlap syndrome when the patient, as the term says, overlap means mixture of the symptoms of one or two or more groups of disease. The patient has mixed symptoms. of two or more groups of disease that we have discussed so far. So overlap syndrome, the patient can present with a skin rash. The patient can present with Sicca syndrome. The patient can have Raynaud's phenomena. The patient can have polymyositis. So patient can have symptoms of the lupus group, can have symptoms of polymyositis, and can also have arthritis. Joint involvement can be present. So clinical features, when the patient, typically a young female, presents to you with symptoms of multiple disease. So till now whatever we studied, so when the cutaneous thing is there, we think of SLE. But patient also has symptoms of Sicca, dryness. Patient also has painful weakness and joint involvement. So there is a overlap of symptom. So clinically, it is not possible to categorize the patient into any one group. That's why we call it a overlap. There is symptoms of two or more groups of disease. Okay. So what is happening here? Screening antibody. So along with the clinical feature, we also have screening antibody of both group of disease. We also have screening antibody of both group of disease. No group of disease. There is ANA positive and RA factor positive. There is both ANA positive and RA factor positive in this patient. So when do you say that patient has overlap syndrome? When the patient has manifestations of multiple disease and patient has antibody of two different groups of disease. That is when we categorize the patient as overlap syndrome. Because what we do, we cannot identify the cause now, because symptoms are also there, antibody also there. So whatever we learned till now, the approach does not work here, because the patient has got overlapping feature and overlapping antibodies. Overlapping feature and overlapping antibodies can be present. Then we call this patient as suffering from overlap syndrome. In this patient, we can go for further specific antibody testing. In this, so first we have reached the diagnosis overlap syndrome. Further, to fine tune the diagnosis, because we have learned till now, first topic we remembered, if you reach lupus group of disease, that is by clinical suspicion and ANA, you go for specific antibody, then you can call it as either SLE, Sicca or systemic sclerosis. Same way, overlap syndrome is a group. Within the group, you will ask for specific antibody testing. If present, you will give the specific diagnosis. So number 1, U1 RNP positive. If the patient of overlap syndrome is U1 RNP positive, then you call the disease as MCTD. Then you call the patient's diagnosis as MCTD, mixed connective tissue disorder. If the patient has got anti-CCP positive, we know cyclic citrullinated protein, which is most specific for RA. So we call the patient as suffering from lupus. RA and lupus, both are there. So we put it as the lupus. We can say the patient is having lupus, right? So patient is having not just multiple symptom, but also both screening antibody. Then you call it as overlap. In the overlap, if the patient is U1 RNP positive, then you give final diagnosis as mixed connective tissue disorder. Along with the overlap, if anti-CCP is positive, then you say patient is suffering from lupus. Patient is suffering from lupus. And if none of these antibodies are present, then you call them as undifferentiated overlap. Then you label the patient as undifferentiated overlap. Then you call it as the undifferentiated overlap. We are going to call this. Okay. So specific antibody can help us reach the diagnosis. So in clinical practice, why do we have to go for a specific antibody? Mainly when we want to plan the treatment, and second for documentation, so that we can do research that this is the specific disease. So without the reaching final diagnosis, even if I know that patient is having overlap syndrome, we can start with the treatment, because these names, whether it is MCTD or it is lupus, it is for documentation only. It does not change the treatment protocol. Okay, listen carefully. In a patient with overlap syndrome, you need not compulsorily do the specific antibody, because it may not change the treatment. We do whenever it is possible, especially financially possible, we do the specific antibody only for documentation purpose. Only for documentation purpose. Okay. Otherwise, you can start the treatment of overlap syndrome. So how to treat overlap syndrome? The treatment of overlap syndrome is a common protocol. The treatment of overlap syndrome is a common protocol. It does not depend. This is the same protocol whether the patient is MCTD or lupus or undifferentiated. Whichever category the patient falls into, the treatment protocol is the same. The treatment protocol is the same. So we have to divide the treatment protocol based on whether it is SLE dominant overlap or RA dominant overlap. So we have to differentiate, plan the treatment based on whether the overlap, which has features of both lupus also, arthritis also, but we want to choose which is dominant. We want to choose which is dominant. You have to treat the dominant disease, because we have studied so far that the first line of treatment, if it is SLE dominant, it will be steroid, but if it is RA dominant, then the first line of treatment is DMARD and not steroid. That we have already studied. So now we know that if a patient has overlap syndrome, then we will have to choose which is dominant, because then only we can start on the first line of treatment. So how do we make that choice? The choice is based on, the choice is based on the type of arthritis. The choice whether the patient is SLE dominant or RA dominant is based on whether the type of arthritis. It is based on the type of arthritis. If it is non-erosive, then you start the patient on steroid. If it is non-erosive, you start the patient on steroid. And if it is erosive, you start the patient on DMARDs. If the patient has erosive arthritis, you start the patient on the DMARDs. This is the treatment protocol of the overlap syndrome. Whether it is MCTD, whether it is lupus or it is undifferentiated, does not matter. Those names are for documentation only. Okay, multiple doubts. Answer to that doubt, whether ANA and RA factor must be positive. Answer is yes, 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 yes and yes. Okay, because that many times is how many times I must have told you that point, that both the screening antibody must be present. That is when you can say that it is overlap syndrome. After the diagnosis, you look at the type of arthritis. Based on that, you will start with the first line of treatment. You will start with the first line of treatment. But so when you look at the patient, you may feel sorry for the patient, that poor patient is having problems of both lupus bhi hai, RA bhi hai. But that's not right to think. It is a different disease which actually has got a favorable prognosis. Which actually has got a favorable prognosis because it has got better response to therapy. Because it has got a better response to therapy. That's what we want to know. So this is our overlap syndrome which we have completed. So in the first session, what we have done in the first hour of today, we have completed what is core rheumatology. So broadly, if you say, when you talk of rheumatology topic, right, we are basically orienting ourselves. Again, I'm requesting you that as an MBBS, you must know how much knowledge you need. We are not actually going to practice rheumatology tomorrow. No? You want to only answer questions on rheumatology. So few of you were asking how to do this, how to do that, whether this will happen, that will happen. ऐसा मत सोचो, है ना? That is not right now for you to think. है ना? So right now we have to focus on the approach. So please look at it from the start. Let us look at it from the start. Everybody, okay? Go back to the first page, okay? Just we can revise. So what we have got here, that we started our day 1. We said, okay, everybody, have you completed writing? Only for 5 minutes. I want you to finish and listen to me. For the next 5 minutes, I want you to just listen to me, the summary of what we have done so far. Okay. So we started on day 1 with what? The physiology of the immune system. We classified immune system disease. Everybody focus, 5 minutes, notes in front of you. If you want to recall, focus here. So patient, we discussed physiology of immune system. Immune deficiency disorder, refer to patho. Among the immune excess disorder, we divided them into 2 groups. Innate excess, we discussed the topic auto-inflammatory disorders or the periodic fever syndromes we discussed. Under autoimmune disease means adaptive excess states. Adaptive excess state, we discussed that they can be organ specific or systemic. If the disease affects only one or specific organ, then their disease is dealt by the specialist of that system. But when the manifestation is multi-organ, those patients need reference to rheumatologist. Those patient needs reference to rheumatologist. Now further, when will you suspect autoimmune disease? You will suspect autoimmune disease when the patient has unexplained fever. So infection tests are negative, you suspected autoimmune disease. In a suspected autoimmune disease, the screening test is ANA. If ANA comes positive, you will say autoimmune disease. Along with ANA, if the patient is also multi-organ, you will say it is rheumatology disease, which is ANA positive. Within rheumatology disease, if ANA is positive, you are likely to be dealing with either lupus group of disease or overlap syndrome. Either lupus disease or overlap syndrome. More likely lupus disease. Within the lupus disease, we discussed that how to differentiate and reach the final diagnosis of SLE, systemic sclerosis and Sicca syndrome. Then we went on to the second group, arthritis syndrome, who present with deformity, predominant joint involvement. We discussed the topic rheumatoid arthritis, the differential spondyloarthropathy and crystal-induced arthropathy. Then we came to vasculitis syndromes, which we divided based on size of the vessel affected. Large vessel, medium vessel and small vessel, and discussed the approach to the diagnosis and the treatment of individual syndromes. The miscellaneous 2 topics that were remaining. 1, myositis group of disease. So inflammation in the muscle. Previously, this topic was in neurology. because please listen to me carefully, not all myositis are rheumatology. Majority myositis affect only the muscle. That's why it was under neurology. But since they have 10 to 30% association with autoimmune disease and inflammatory in nature, Harrison has decided to gift that topic to rheumatologist. Key reference goes to rheumatologist, myositis. So today we discussed the points. We discussed polymyositis, dermatomyositis and inclusion body myositis. And then we came to the final overlap syndrome, when the patient has feature of lupus disease, arthritis, poly and or dermato. Please remember, autoimmune association is seen with both poly or dermatomyositis. If it is there, along with ANA and RA factor positive, you are going to call it as overlap syndrome. And in overlap syndrome, you want to start the idea what is dominant and start the respective treatment. So prognosis is overall correct. Okay, so this is where we have reached today. To continue, one of the rheumatology disease only is the acute rheumatic fever. So this becomes our connection to cardiology. This becomes our connection to cardiology. Okay. So sarcoidosis you will study under respiratory class. Sarcoidosis you will study under the respiratory class. Right. So we have got acute rheumatic fever to complete our rheumatology sessions. Okay, everybody. So let us start here. Okay, there is to look at acute rheumatic fever. Okay, acute rheumatic fever. Post-pharyngitis sequelae following infection by. Let us start with the definition. Everybody, now very fast. Everybody, this is very simple topic, very important topic. So note down clinically important points here. Come on, let us start with me. I hope last point, last disease, proforma is clear to you and you will remember this. You will remember this. Okay, the proforma and use it for all the systems you are going to study. Okay, after this you are having nephrology class sometime in the future. Hopefully lockdown will get over. Otherwise we will meet again on online for cardiology sessions. Okay, so we are starting with our acute rheumatic fever. We don't want to waste any time. We'll start with acute rheumatic fever. Start with the definition. Start with the definition. Right? So post-pharyngitis. It is a post-pharyngitis. Post-pharyngitis sequelae following infection by group A beta hemolytic streptococcus. So what is it? It is a post-pharyngitis sequelae which is following infection by group A beta hemolytic streptococci. They are called as the gas group of organism. Gas group of organism. Okay. So group A beta hemolytic streptococci. Group A beta hemolytic streptococci. We want to know. So what is epidemiology? Everybody focus. What is epidemiology? Rheumatic fever. Rheumatic fever is affecting young children, school going age. It can affect young children 5 to 15 years, male equal to female. Male equal to female, that is school going age is affected. It is the school going change. Okay, so it is basically why school. Answer is right below. Why the school is the favorite site, hunting ground for rheumatic fever? ध्यान से देखो. Because risk factor is there. Risk factors are overcrowding and poor sanitation, which is prevalent in our schools, right? So school going children are at the highest risk of developing streptococci infection, and after streptococci few of them can develop a sequelae. Few of them can develop a sequelae, which is your acute rheumatic fever. Okay, understand this clearly, that acute rheumatic fever is a immune response following streptococcal infection. It is not an infection itself. It is a autoimmune disease following streptococcal infection. So why should happen? Why should it happen? So what is the pathology? We studied on day 1. We studied on day 1. One of the mechanisms for autoimmune disease is molecular mimicry. One of the mechanisms for autoimmune disease is molecular mimicry. Molecular mimicry. Right? Means what? There is cross reaction. There is cross reaction between the streptococcal antigen and the self antigen present in the heart and the joint. So there is a cross reaction which is present, between streptococcal antigen and the self antigen present in the heart and the joint. Please remember William Osler's dictum for rheumatic fever. William Osler quoted that rheumatic fever, what does it do? Bites the heart and licks the joint. Rheumatic fever bites the heart and licks the joint. So these are the two common organ systems affected due to rheumatic fever. So pathology is the molecular mimicry. Because there is a cross reaction. The streptococcal antigen looks similar to the antigen which is present in heart and the joint. So start with the clinical feature. Let us start with the clinical feature. Chalo. So faster you write today, faster you can go home. Okay. So we'll write fast. So clinical feature. Let us start with the clinical feature. Clinical feature number 1, migratory polyarthritis. Clinical feature number 1, migratory polyarthritis. Okay, migratory polyarthritis, which is the most common manifestation present in 85% of the cases. Migratory polyarthritis is the most common. It is the most common present manifestation of the disease, which there is never residual deformity. So it is also like lupus. There is never residual deformity. So this is also a very common viva question. What is the difference between joint involvement of rheumatic fever and rheumatoid arthritis? Listen carefully. What is the difference between joint involvement in rheumatic fever and rheumatoid arthritis? They are two different diseases. In rheumatic fever, joint involvement is never erosive. Again, non-erosive. It is non-erosive. While rheumatoid arthritis, it is erosive. That is the difference between the two. So here, when the child comes with joint pain, all you have to do is give NSAIDs. There is no DMARD because there is no erosion. So you don't have to prescribe DMARD. All you have to prescribe is palliative treatment with NSAIDs. So migratory polyarthritis is the commonest presentation of rheumatic fever, but luckily it is benign and needs only symptomatic treatment with NSAIDs. Next point here, pancarditis. So arthritis is not our worry. Arthritis is common but not our worry. What is dreaded is the pancarditis. Dreaded feature is the pancarditis. Is dreaded. Luckily, it occurs only in 10 to 15% cases. Luckily, it occurs in only 10 to 15% of the cases. So pancarditis, as we said, rheumatic fever bites the heart. Okay. So bite can be severe, but it is not as common. Luckily, it occurs only in 10 to 15% of the cases. 10 to 15% of the cases. Right. So what is the problem? We call it dreaded because there is increased risk of heart failure. There is an increased risk of heart failure, and that can also lead to residual valve defect in the future. Can lead to residual valve defect in the future. So the residual valve defect is what is called as RHD, rheumatic heart disease. Residual valve defect is the one which is called as rheumatic heart disease. Right? It is called as the rheumatic heart disease. So what is the treatment? The carditis is an indication for steroid therapy. So cardiac involvement in rheumatic fever is an indication for steroids and bed rest, because they reduce the risk of heart failure. They reduce the risk of heart failure. So polyarthritis is a common feature, but carditis is the dreaded feature, which can lead to heart failure also, which can lead to rheumatic heart disease also. So you need to start the patient on steroids and bed rest. You need to start the patient on steroids and bed rest. Right? Continue further. Third manifestation. The third manifestation are the subcutaneous nodule. Third manifestation is the subcutaneous nodule, which occurs only in 5 to 10% cases only. Subcutaneous nodules which occurs in 5 to 10% of the cases only. Subcutaneous nodule which occurs in 5 to 10% of the cases only. But what are they? They are painless nodules. Subcutaneous nodules are the painless nodules over the extensor surface. They are the painless nodules over the extensor surface which don't require treatment. Okay. So even though it is a manifestation which you will use it as a part of the Jones criteria for diagnosis, the manifestation itself does not require treatment. The manifestation does not require treatment because it is a painless condition. Because it is a painless condition. Number 4 is the erythema marginatum. Number 4 is the erythema marginatum. Number 4 is the erythema marginatum. 5 to 10% cases only. So incidence of this feature is not common, and they are not dangerous also, because as you can see, it is a non-pruritic faint rash. It is a non-pruritic faint rash. It is present. Non-pruritic faint rash is present, which can be best seen only in the fair or white skinned people. So in European and Western population, it can be more obvious as compared to the Asians. So this manifestation may not be easy to identify. But since it does not cause any trouble to the patient, this manifestation also does not require treatment. This manifestation also does not require treatment. The number 5, the least common manifestation. Number 5, the least common manifestation is chorea. Number 5, the least common manifestation is chorea, which occurs in less than 1% cases only. But even though it is least common in practice, it is very important for MCQ. Even though it is the least common feature in practice. It is most important in MCQ. So what are the points? So chorea, what I am writing? We are writing characteristic feature of this manifestation. We are writing characteristic feature of this manifestation. It is the only manifestation. It is the only manifestation which is more common in females, which is more common in the female. That means indirectly you can derive that arthritis and carditis are more common in the male. That is indirect derivation. Only the fifth, chorea, is the manifestation of rheumatic fever which is more common in the female. Which is more common in the female. And it is the only manifestation which can occur up to 6 months after acute rheumatic fever. So it is the only one which can come up to 6 months after the attack of acute rheumatic fever. That is very important to us. Okay. So the carditis, arthritis occur during the acute rheumatic fever. But chorea can occur up to 6 months after. Up to 6 months after this, the rheumatic fever is over. Another points are there. Self-limiting. It is the self-limiting. Self-limiting, and it may persist for 2 to 3 years. It is self-limiting and may persist for 2 to 3 years. Self-limiting may persist for 2 to 3 years. And chorea, you will read, you have done in neurology, presents as quasi-purposive movement. You have studied chorea in neurology. It presents as quasi-purposive movement. Quasi-purposive means semi-purposeful movement. Semi-purposeful movement it can cause. And the treatment of choice is sodium valproate. The treatment is the sodium valproate. Drug of choice for this manifestation is the sodium valproate. So please remember that NSAIDs are given for arthritis. Steroids are given for carditis. Valproate is given only if chorea is present. So we have written down the 5 clinical manifestations of rheumatic fever along with their description. The 5 clinical manifestations of rheumatic fever along with their description. So you will suspect the disease. Once you suspect the disease, how to diagnose? How to diagnose the disease? The diagnosis is the one. We use modified Jones criteria. For diagnosis of the disease, we use modified Jones criteria. Okay. So diagnosis of the disease is done by the modified Jones criteria. Haloperidol. Haloperidol was previously prescribed for chorea, but valproate has better efficacy and better safety in the children, and that is why it is the preferred drug now. So when you suspect, when a young boy or a young girl presents with the clinical features of rheumatic fever, you will suspect the diagnosis. When you suspect the diagnosis, you want to do modified Jones criteria. So I want you to focus here. I want you to focus on the updates. What are the changes? The Jones criteria is very old and it gets frequently modified. We want to know what are the changes. So start with the first points. Essential. So changes, updates, we will put it in red. Updates, we will put it in red. So essential criteria. What is essential criteria? Essential criteria is to have a documented evidence. Is to have documented evidence of streptococcal pharyngitis. You must have documented evidence of streptococcal pharyngitis must be present. Okay, must be present. Because rheumatic fever, to say that it is rheumatic fever, you must prove that there was a history of streptococcal pharyngitis. That is considered essential criteria. That is mandatory criteria. So ideally, how can you document? Ideally, how can you document streptococcal infection if it is throat swab positive? Ideally, if the throat swab is positive, culture is positive for streptococci, then there is no doubt that there was a streptococcal infection. But ideal is not often done. For every sore throat, we don't collect throat swab. So this result may not be always available. This result may not be available. So what is preferred in our country? What is preferred is the rising antibody titer. What is preferred is the rising antibody titer. And you can see most common antibody in rheumatic fever is the ASO, anti-streptolysin O antibody. Most common antibody in rheumatic fever is the ASO, anti-streptolysin O antibody, which is the sensitive, most common antibody present. So if there is a rising titer, that also can be taken as essential criteria. That can also be taken as essential criteria. And last, you can also go for streptococcal antigen test. You can also go for streptococcal antigen detection. You can also go for streptococcal antigen detection, which can be taken as a part of essential criteria. So out of these three tests, you want any one at least to be positive. You want at least one to be positive to say that it can be rheumatic fever. Okay, so this is called the essential criteria. This is called as the essential criteria. So update number 1. Let us write the update in the criteria. What has changed in the criteria? For so many years, this demand was there. For many years, the demand was there. Listen carefully to the clinical reason. The update in the criteria is that echocardiography, है ना, cardio ज़्यादा बार हो गया है ना, उसको डिलीट कर देते हैं. So echocardiography, right? So the echocardiography, है ना, लास्ट पॉइंट क्या है ना, लास्ट पॉइंट क्या है, अप्रूव्ड ऑल्टरनेटिव. लास्ट पॉइंट है आपका अप्रूव्ड ऑल्टरनेटिव. स्ट्रेप्टोकोकल एंटीजन टेस्ट कैन ऑल्सो बी डन. Streptococcal antigen test can also be done. So for diagnosis, you need any one of this to be positive. You need any one to be positive. Okay, to say that it is a essential criteria. You need any one to be positive to say it is an essential criteria. Continue further, right? So approved alternative, approved alternative. Alternative matlab instead of the throat swab or the antibody, you can do this also. So one update that we have is echocardiography is approved to detect carditis in an asymptomatic patient. Echocardiography is approved to detect carditis in an asymptomatic patient, that is in subclinical cases. That is in the subclinical cases. So please remember the clinical importance of this update. You must understand the clinical importance of this update. The child, the common category who is affected by rheumatic fever is a child. Children are usually otherwise healthy, so they have very good cardiorespiratory reserve. Listen carefully. Children are otherwise healthy, so they have very good cardiorespiratory reserve. That is why in mild cases of carditis, the child may not have symptom. In mild cases, the child may not have symptom because the child is otherwise healthy. But if the symptom is not there, we were not able to count carditis as a diagnostic criteria. But now that has been solved. That has been solved by including echocardiography to detect carditis in an asymptomatic case. So this problem has been solved by approving echocardiography to detect carditis in asymptomatic cases. So when a child may not have the symptom of carditis, but if you suspect rheumatic fever, you must perform echocardiography. Continue further. So the new update number 2, update in red. What is the change? The Jones criteria has divided the population into two. The modified Jones criteria has made two different set of criteria based on the population. They have divided into the two based on the low risk and high risk of rheumatic fever. Based on low risk and high risk of rheumatic fever, we have got this here, right? So incidence of based on. So how to divide? Please note this point. How to divide the population? The population is divided into low risk and high risk based on incidence of acute rheumatic fever and the prevalence of rheumatic heart disease in the population. So two things are taken into the points. Anna, Chitresh, asymptomatic means asymptomatic for carditis. Other features can be there, no? I told also, when young boy has joint pain but no symptom of carditis and you suspect rheumatic fever, you must perform echocardiography. Okay? So that is what you must know, please. So here, how to divide the population? Population is divided into the two. One, based on incidence of acute rheumatic fever and in the prevalence of rheumatic heart disease. Incidence of acute rheumatic fever and prevalence of rheumatic heart disease. We must know. So when do you say patient is low risk? So when do we say patient is low risk? Patient is considered as low risk for rheumatic fever. Patient is considered low risk for rheumatic fever when the incidence is less than 2 per 1 lakh population. When the incidence of rheumatic fever is less than 2 per 1 lakh population and the prevalence of rheumatic heart disease is less than 1 per 1 lakh population. So we are dividing the patient into two groups, low risk and high risk, taking into consideration two factors. Incidence of rheumatic fever and prevalence of rheumatic heart disease. Incidence is less than 2, prevalence of RHD is less than 1 per 1 lakh of population, we call them as low risk. High risk population when it is more than equal to 2, more than equal to 1 respectively. More than equal to 2, more than equal to 1 respectively, we can call them into the high risk category. So why we need two set of guidelines. So the diagnosis is same for rheumatic fever. The criteria is same, Jones criteria. But the criteria is different for the low risk population, different for the high risk population. Different for low risk, different for high risk population. Low risk population, try to understand. Low risk population में we want the criteria. Low risk population में we want the criteria to be specific. In the low risk population, we want the criteria to be specific, because in the low risk, we don't want people to be unnecessarily diagnosed as rheumatic fever. In a low risk population, we want the criteria to be more specific so that we don't want unwanted diagnosis. But in a high risk population, we want the criteria to be sensitive. We don't want to miss a single case. In a high risk population, we want the criteria to be sensitive. We want the criteria to be sensitive because we don't want to miss the case. Okay, understand the purpose of this classification. We have divided the population into two because there is a problem. If I use the same criteria in low risk and high risk, low risk population will have over diagnosis. High risk population may have under diagnosis. So to deal with this problem, I have made different set of criteria for low risk and high risk population. We have made the different set of criteria for the low risk and the high risk population. We are continuing this table only, right? So continue further. So 5 major criteria is there. There are 5 major criteria. There are 5 major criteria. Among the 5 major criteria, number 1 is the joint involvement. Number 1 we have got joint involvement. So in the low risk, please remember, green low risk, purple high risk. Okay, these are the two. Specific. In the major criteria, joint involvement in the low risk population. When do you say joint involvement satisfies major criteria? Only when there is polyarthritis. Only when there is polyarthritis. Then only you will say major criteria positive in a low risk population. Only when there is polyarthritis. Definition you already know. But in a high risk population, in a high risk population, we have made the criteria sensitive. We have made the criteria sensitive. So whether the child has polyarthritis plus or monoarthritis or even polyarthralgia. Polyarthralgia is now become a major criteria. Please note it. Polyarthralgia has now become a major criteria. Previously, old criteria, arthralgia was minor, arthritis was major. But now polyarthralgia is a major criteria for the high risk population. It is a major criteria for high risk population. The other 4 manifestations are common to both. So already we have written, just enumerate them, the 5 manifestations. So joint involvement we wrote, carditis, subcutaneous nodule, erythema marginatum and chorea. So the 4 clinical symptoms, that we have written down are constituting major criteria if present in either of the population. In either of the population. This is our 5 major criteria. Minor criteria. What are the minor criteria? Minor criteria are 4 in number. Minor criteria are 4 in number. So there are 5 major you have written down. Now you are writing the 4 minor criteria. The 4 minor criteria. Again, first, joint involvement has changed because now polyarthralgia has become major in high risk. But polyarthralgia is a minor criteria in low risk population. Polyarthralgia is a minor criteria in low risk population, while in high risk population, monoarthralgia. In a high risk population, monoarthralgia is considered minor criteria. Monoarthralgia is considered the minor criteria. Next minor criteria is fever. Next minor criteria is fever. In the low risk, fever should be at least 38.5. In the high risk, fever can be minimum 38 degree only. The fever can be more than 38 only. Okay. Number 3, acute phase reactants. Number 3, acute phase reactant. Common criteria in acute phase reactant: C reactive protein more than 3. C reactive protein more than 3. That is common to both high risk and low risk. That is common to both high risk and low risk. While the ESR has different values for low and high. In the low risk, ESR should be more than 60. In the high risk, ESR should be more than 30. So ESR more than 30 considered minor criteria. So we are looking at the 4 minor criteria. I am going to put up these slides on the Facebook. So please don't panic if your app has hung, your screen went blank. Don't worry. You continue with what is there in front of you. I am going to put up the notes. You can get it also. Why we are worried? I understand that there are technical problems you are getting and it is disturbing. But the app is live in front of me also on my mobile, and so far it's been working perfectly well. There has been no hanging, no black screen. But I get it that there are areas where you might be having problem. Don't worry. I am putting the notes every day on Facebook. So please continue with where I am. Number 4 minor criteria. Number 4 criteria, yes, is the prolonged PR on the ECG. Number 4 minor criteria is the prolonged PR on the ECG. Prolonged PR on the ECG. When carditis is not a major criteria. When carditis is not a major criteria. Okay. So not a major criteria. If you have counted carditis as a major criteria, you cannot use ECG as a minor criteria. When carditis is not there, then ECG changes can be considered minor criteria. Can be considered minor criteria. Okay, CRP is 3, not 330. It is 3. Okay, so major criteria, minor criteria. So we have got the 5 major criteria and 4 minor criteria. So first we have got essential criteria. Essential criteria. So what it is, that is what we are getting. So we are 5 major criteria and the 4 minor criteria. Okay. So Kunal Anand, if you are not getting what I am saying, you mail me, we'll explain again, or see the video again, because the majority seem to be getting what I want to say. Okay. So if there is a problem, you have to revise maybe, and you can go through the video, you will understand it. That's how we will need to go for. So diagnosis, how to confirm the diagnosis. There are 5 major criteria, 4 minor criteria. For diagnosis, we can use 2 major criteria. Either there should be 2 major criteria. Either there should be 2 major criteria, or there should be one major plus two minor criteria. There should be one major plus two minor criteria to identify a new case. To identify a new case. So out of the total criteria, essential तो होना ही चाहिए. Essential is compulsory. Along with essential, if there are two major criteria, or if there is one major plus two minor criteria, you can confirm a new case of acute rheumatic fever. You can see new case of acute rheumatic fever. But if there are three minor criteria, only three minor criteria, only having three minor criteria, it is only for relapse. It is only for relapse. Three minor criteria is only for relapse. So you can say that to diagnose a new case, to diagnose a new case of rheumatic fever, at least one major criteria is essential. For diagnosing new case, there should be at least one major criteria present. Only three minor criteria can be used for diagnosis of a relapse patient who is already a case of acute rheumatic fever. Okay, fifth minor criteria है ही नहीं, है ना ध्वनि जोशी. Fifth minor criteria does not exist. Very good. Thank you, Shubham. Only four are there. Great. Thank you very much. We'll continue. So once we have diagnosed the situation, we go to the treatment. So treatment is to start the patient on penicillin. So penicillin, preferred is to give single dose benzathine penicillin. Preferred is to give single dose benzathine penicillin. Preferred is to go for single dose benzathine penicillin. What is the dose? 1.2 million unit. The dose is 1.2 million unit intramuscular. Okay. Essential criteria is essential for everybody. Okay. वो relapse है, new case है. Essential is essential. Okay. Compulsory. That is common. Penicillin preferred dose is to give single dose benzathine penicillin at a dose of 1.2 million unit. 1.2 million unit intramuscular you want to give. So why do you want to give? Because we said rheumatic fever is not an infection. Then why to give penicillin? That's the answer. So why to give penicillin? We want to know. Why to give penicillin? We want to give penicillin even though rheumatic fever is autoimmune, to eradicate residual streptococcal infection. To eradicate residual streptococcal infection. To eradicate residual streptococcal infection. And also, if you can give penicillin, it is known to reduce the risk of rheumatic heart disease. It is known to reduce the risk of residual valve involvement. It is known to reduce the risk of residual valve involvement. Okay. So patient, after confirming the diagnosis of acute rheumatic fever, you want to start the patient on penicillin therapy. Along with penicillin, you will give palliative therapy depending on the manifestation, which we already discussed. So penicillin should be given to all cases of rheumatic fever. Penicillin should be given to all cases of rheumatic fever. Along with penicillin, if the patient has arthritis, you will give NSAID. If the patient has carditis, you will give steroid. And if the patient has chorea, you want to give valproate also, sodium valproate also. Okay. So the simple points here, that after confirming rheumatic fever based on modified Jones criteria, you will give the patient penicillin and start the patient on palliative therapy. If penicillin is sensitive, then you switch to erythromycin. Then you have to start the patient on erythromycin. Okay, so patient has to go for erythromycin if they are sensitive to penicillin. If they are sensitive to penicillin. Okay, so I will come to the major criteria at the end again. I will come again to major criteria at the end. Leave that much space and continue forward. Okay, so after this, what is required? Chronic prophylaxis is required. After the patient has received the acute treatment, you also want to start patient on chronic prophylaxis. You want to start the patient on chronic prophylaxis because there is a high relapse rate. You want to start the patient on the chronic prophylaxis because there is a high relapse risk. Because there is a high relapse risk. So you want to go for the chronic prophylaxis which is needed. Okay, that's how we want to continue. So how to give? What is the duration of the prophylaxis? Next column please. Okay, so what is the duration? What is the duration? What is the duration? Okay, of prophylaxis? The duration of prophylaxis depends on 2 points. So count it please. Count it please. Duration. The duration of the prophylaxis depends upon one, based on number of years after the rheumatic fever. So you will count number of years after rheumatic fever. Number of years after the rheumatic fever, or till the age of the patient in years, whichever is longer. Whichever is longer. Okay, we want to know here. So we want to see penicillin prophylaxis, how long to continue. Either you count it in terms of number of years post rheumatic fever, or till age of the patient in years, whichever is longer. So after the rheumatic fever, number of years criteria ज़्यादा है, continue that. और till age का criteria ज़्यादा है, तो continue till that many years. That is what we want to know. Okay. So what we want to see here, the prophylaxis depends upon the number of years post rheumatic fever or till the age of the patient in years. We want to calculate. And the age of the patient is subdivided into two. That is, one, the low risk and the high risk. There is the low risk and the high risk category where the age criteria is different. As the age criteria is different. Okay, so till what age? In years. So till how many age of the patient you must give the prophylaxis. That is different for low risk, different for high risk. Now we will divide the patient into three categories. We will divide the patient into three categories. Divide the patient into three categories. So after the diagnosis of rheumatic fever is done, you want to know whether the patient is having rheumatic fever but no carditis. One category. One carditis, no carditis. Second category, carditis is present but there is no residual valve involvement. And third category, when the patient has got residual valve involvement. So you want to see. When you want to see, एज का मतलब कितने साल तक हो जाएगा वो पेशेंट तब तक देंगे. थैंक यू वेरी मच, है ना. हाउ टू एक्सप्लेन मोर आई डोंट नो, है ना. एज यू रीड यू विल अंडरस्टैंड. व्हेन आई गिव यू एग्जांपल यू कैन अंडरस्टैंड. All of you are a very restless generation. है ना? चलो, okay. So we will divide the patients of rheumatic fever into the 3. Okay. So divide the duration patients of rheumatic fever into 3. 1, those who have no carditis, those who have carditis but no defect, and those who have got residual valve defect. Those who have got residual valve defect. Now, number of years post rheumatic fever. Number of years post rheumatic fever. If the patient has no carditis, if the patient has no carditis, you will give it for 5 years, up to 5 years after the rheumatic fever. If carditis is there or valve defect is there, then you have to give it for 10 years after the rheumatic fever. Then you have to give for 10 years after the rheumatic fever. Okay, so what we have got here, number of years post rheumatic fever we want to give. So based on that we want to give, this is the duration after rheumatic fever. But compare it in a low risk category. In a low risk category, so age criteria क्या है? In rheumatic fever without carditis, you must continue prophylaxis up to 18 years of age. In carditis, you must give up to 21 years of age. And residual valve disease, you give it up to 40 years of age. You give it up to 40 years of age. Okay. Chronic prophylaxis for the acute rheumatic fever. Chronic prophylaxis for the acute rheumatic fever you have to give for this duration. So example लेते हैं ना, how to use these two tables together. Take an example. So low risk means Western country. Let us take an example. Low risk means Western country. If the patient has come with rheumatic fever without carditis at 15 years of age. Listen to the question. In Western country, that means low risk population, patient has been diagnosed with rheumatic fever without carditis at 15 years of age. How long will you continue prophylaxis? That's the question. So when patient is 15, he has got rheumatic fever, but he fits into the category with no carditis. He fits into the category no carditis. So what we will be the based on first criteria, 15 plus 5. So he has to give 15, presently he is 15 years of age. Now you have to give it for 5 more years according to the first column. That means you have to give it till he becomes 20 years of age. That means you have to give till he becomes 20 years of age. By the age criteria, it is up to 18 years of age. So between the two columns, whichever is longer. So by first column, you are getting answer 20 years. By second column, it is 18, which is longer up to 20 years of age. That is how you must continue. That is how we must continue. So what we have to do, we have to use both the columns together, out of which whichever duration is longer. So we have to give it for that many years. While in the high risk category, you want to give it for up to 21, 25 or lifelong respectively. You will give it for the 21, 25 lifelong respectively. So when the patient, now take another example. Patient in India has got rheumatic fever with valve involvement. Patient has got rheumatic fever with valve involvement in our country. Then there is no question. You have to give it for lifelong. Then you have to give lifelong prophylaxis. Then you have to give lifelong prophylaxis has to be given. Okay, that is how we plan prophylaxis. What is given in prophylaxis? Prophylaxis in given penicillin injection only. And if they are sensitive to penicillin, you are going to give erythromycin. So for prophylaxis also, you continue benzathine penicillin. If they are sensitive to penicillin, you will continue oral erythromycin for the desired time. Now, what is the point? What is the frequency of the injection? How frequently should give? So in our country, every 3 weeks, we give penicillin injection every 3 weeks for the duration that we just discussed. Okay. So come to the last table of the day, last table of rheumatology session. Last we have come to that what is the most common valve defect. What is the most common valve defect? इसको ध्यान से पढ़िए. Question you have to read clearly. Most common valve defect in acute rheumatic fever and most common valve defect in rheumatic heart disease is different. This is our concluding slide. Most common valve defect in acute rheumatic fever and rheumatic heart disease is different. In acute rheumatic fever, most common valve defect is mitral regurgitation. Most common valve defect in acute rheumatic fever is mitral regurgitation because valvulitis, inflammation of the mitral valve, causes them to become incompetent. That's what we must know. So in acute rheumatic fever, most common lesion is mitral regurgitation. But in a patient with mitral stenosis, but in a patient with rheumatic heart disease, mitral stenosis is the most common valve defect. In the patient with rheumatic heart disease, most common lesion is mitral stenosis. So as a valve, mitral valve is most commonly affected. But in acute phase, you get MR. In long-term disease, rheumatic heart disease, we get mitral stenosis. Mitral stenosis due to commissural fibrosis. Because we all know in chronic disease, there will be fibrosis. Inflammatory tissue heals by fibrosis. And we end up getting mitral stenosis. Right? So this is our final slide of the rheumatic fever. So remaining the valve disease, everything else we will continue whenever we meet for cardiology. Right? So penicillin frequency you are asking, just note it down. Penicillin frequency, when to give penicillin you are asking. So penicillin should be given every 4 weeks in the low risk population. Every 4 weeks in the low risk population and every 3 weeks in the high risk population. So benzathine penicillin should be given every 4 weeks in low risk population. Okay, and every 3 weeks in the high risk population. So in our country, we have to give penicillin every 3 weeks. In Western country, we have to give it every 4 weeks for so many years that we already discussed. Right? So what is the point? So let us conclude by this very point. Major criteria I will explain, don't worry. Okay, I will come back to you, don't worry. So let's conclude our sessions. Rheumatology we have done together, and the famous quote, I think we are all familiar, right? So success doesn't happen overnight. Keep your eye on the prize and don't look back. है ना? सो मोटिवेशन मैसेजेस पढ़ने को अच्छा लगता है, बट क्या होता है ना, ये जो प्राइस, कीप आई ऑन द प्राइस एंड डोंट लुक बैक, वेरी डिफिकल्ट टू फॉलो ना. ऑल ऑफ यू विल अग्री विथ मी, है ना? दिल से आवाज आती है, अबे पलट, है ना? वेन एवर यू फिनिश रीडिंग अ टॉपिक, ऑलवेज यू वॉन्ट टू लुक बैक कि भाई आता है कि नहीं आता है, भूल तो नहीं जाएंगे, है ना? योर माइंड क्रिएट्स डाउट्स. So we all know that we will not become successful in one time, and you have to focus on target and keep looking forward. But we all have a tendency to look back because we feel underconfident. And not just us, na? Not just us, even we get it from our near and dear ones. वो भी बोलते हैं तुझे कुछ नहीं आता है ना. They also start making undermining your confidence that do you really think you remember, है ना, again study. So please remember, what is the rule? What is the rule you have to do? What is the rule? The rule is to shut our critics. The rule is to shut our critics. Anna, please remember, rheumatology mechanism जैसा both endogenous and exogenous critic को बंद करो. अपने दिल की आवाज भी नहीं सुनो, बाहर के लोगों की भी नहीं सुनो. जो बोलते हैं कि आपको नहीं आता उनको भूल जाओ, है ना. तो you shut your critics. Don't listen to our own voice which tells that maybe we will not remember. Other people who say that you won't remember, just leave them alone. Okay, just leave them alone by working hard and talking less about it. Anna, that is very important message. What we want to do, we want to work and talk less. Work hard, talk less. Because the final line you must remember, what you do is louder than what you say. Please remember these words. What you do is louder than what you say. So make sure you work hard, work smart, and achieve your goal. Okay, that's what we want to see. And my final line is simple, my Gmail ID, right? So till we meet again, you can post your doubts here. Whatever doubts are remaining, I will answer for you. Don't worry, I will answer for you. Major criteria, I will take you back. Erythromycin, I told you that penicillin is the drug to give for prophylaxis. But if the patient is allergic to penicillin, then as an alternative, you can give erythromycin. Then as an alternative, you can give erythromycin, right? So till we meet again, you can put your doubts on Facebook page or you can post it to my Gmail. Yes. So everybody, for all the Tamil people also, நான் உங்களோட தான் இருக்கேன். எப்போனா நீங்க மெசேஜ் பண்ணுங்க. We are all together. So whole country, come on. So let's be together. Together we can. That's the only way forward, right? Chalo. All the best. Others can run away. Only those who have got doubts, you can put it here. Let me try to explain for you. Okay, let me try to explain for you. Again, for revision, you can go to the eMedicos app, go to class images. You can see what is the images that will help you revise the topic. That will help you revise the topic, right? So dose of penicillin remains the same, 1.2 million unit. Okay, chalo. So now I will take you to major criteria and then we will call it good night. Anna, Malayalam I don't know. By next time I will learn something. Chalo. Good night everybody. Run away. Major criteria and then we will close. Right. So major criteria slide. Major criteria smile. We want to look at this, right? Major criteria, joint involvement. So please remember, I have classified the population already. The population is classified into two. We have got the low risk population in green and high risk population in the purple. Low risk population in the green, high risk population in the purple, right? So polyarthritis, okay, only is a major criteria. Polyarthritis only is a major criteria in the low risk population. In the low risk population, only polyarthritis is a major criteria. But in a high risk population, even monoarthritis. In a high risk population, even monoarthritis and polyarthralgia is now considered major criteria. It is now considered a major criteria. Okay, that's what it is. So understand that. And the other criteria were carditis, subcutaneous nodule, erythema marginatum and chorea. Erythema marginatum and chorea, right? So that is where we are. So we'll see you soon. Okay, all the best, keep learning and stay safe. Yes, thank you. Chalo, run away. Good night.